Good afternoon and welcome to our second poster session for the annual AOCA conference. I'm Suzanne Huffnagel, the chair of the Scholarly Activities Committee. I'm going to run the session. These are my fellow moderators on the end, Dr. Sean Washak, Dr. Mario Gonzalez, my sister, Dr. Jane Huffnagel, the good twin, and Suzanne Huffnagel, the evil twin. This session is supposed to start at 11:30. It's a little bit late getting started, but that's okay. Going to run to 12:15. It's going to showcase 4 complex case abstracts in poster form. And then our final abstract session will be oral abstracts presented from 12:30 to 2:30 this afternoon. In this session, each author will have 5 minutes to present his or her poster and entertain a few questions from the audience. And then we as moderators are going to be scoring these presentations, and you, the audience, will have a chance to put in your scores as well. If you are on the conference app, and you'll see where these presentations are listed. There is something above them that says take survey. You click on that. There will be 3 questions for each one of these authors from 1 to 10, and you score all of them and send them in. Your results will be added to our moderators' results, and then the top 2 posters, one in scientific investigation and one in complex case, will be given an award announced at the conclave tonight. We want to, as I said, stay to a strict schedule so that everybody gets their time. Authors, thank you for presenting and coming, and audience, give them your attention. So the very first one is our first poster presentation is a complex case entitled Challenges of General Anesthesia in an Elderly Patient Undergoing Left Internal Carotid Endarterectomy with Chronic Obstructive Pulmonary Disease After Revascularization for Subclavian Steal Syndrome. Quite a mouthful. This will be presented by Cyrus Ghaffari, a student from Midwestern University, Arizona College of Osteopathic Medicine. We'll have the speaker come up, and audience, give him your attention.
All right. Thank you, Dr. Huffnagel. Thank you for saving me the name of the title as well. I understand it is a bit of a mouthful. So, my name is Cyrus Ghaffari, 4th-year medical student from the Arizona College of Osteopathic Medicine. Thank you all for having me here today. So I will just go ahead and get started right away with our case. So carotid endarterectomies, these are fairly involved procedures. They do require a good amount of communication between the anesthesia providers and the surgical team, particularly because of the relevant anatomical structures involved in the procedure, namely the carotid baroreceptors. So upon manipulating these structures, we can have some pretty labile changes in blood pressure throughout the procedure. You can already kind of tell that from the first figure there, but I can get into that more in detail. So ultimately, the main concern from at least an anesthesia perspective is adequate cerebral perfusion. So that is one thing that we want to monitor very closely during this case. So who is our patient? Our patient is an 82-year-old female, again with a history of COPD. She was revascularized for subclavian steal syndrome in 2020. She also has a history of hypertension, anemia, and atrial fibrillation. Let's see. As far as her medications, they are pretty concordant with her comorbidities. As far as preoperative vitals and her physical exam, nothing really remarkable or impressive about them. They are more or less within normal limits. The only real lab abnormality was a hemoglobin value of 9.9, but this did not significantly affect our management of the case. So what did we do for this patient intraoperatively? So we induced the patient with propofol, and sevoflurane was used for maintenance anesthesia. We also completed a rapid sequence intubation with succinylcholine, followed by rocuronium as needed for paralysis. An arterial line was placed, and a cerebral oximeter was used to manage, to basically assess the patient's cerebral perfusion. So upon elevating the head of the bed, which is necessary for surgical access, the patient became rather hypotensive, and so norepinephrine and phenylephrine were used to maintain the patient's hemodynamic stability during the case. It is suggested to keep the patient at a mean arterial pressure of about 20% above the patient's resting blood pressure, at least for a good portion of the case, and I can get into those details a little bit more. Nicardipine was also kept on standby in the case of excessive hypertension. Let's see. So once the head of the bed was elevated, we proceeded with the case. One of the first main, I guess, checkpoints, at least from an anesthesia standpoint, is to, when the carotid artery is clamped, before this happens, we need to administer heparin prophylactically to prevent thromboembolic events. Along with that, we also needed to administer calcium chloride because heparin can actually bind up a lot of the blood's calcium, which could then result in hypotension, so that is an important step as well. Once the carotid artery is clamped, the patient will remain in a hypertensive state because ultimately we are now basically canceling out one of the main areas of blood supply to the brain. Once this is done, a shunt is placed to circumnavigate the area of anatomical dissection. The shunt is then removed once that is completed, and then the patient is remained at a normotensive state. Protamine sulfate was given to reverse heparin, although this needs to be done slowly because this can also result in a basically a dip in the patient's blood pressure. Sugammadex was given for reversal and for the completion of a neurologic exam postoperatively. Ultimately, with these steps, our patient recovered well, and a neurological exam did not reveal any deficits after that. So that is the main points of my case. Obviously, just really focusing in on the blood pressure management. On the graph, another thing, ventilation settings were kept so that the patient was normocapnic. An excess in CO2 or a decrease in CO2 can also affect cerebral perfusion, so this was kept at a normocapnic level. Referring to my figures, the main one that I want to point you to is the top figure with the green line, that is arterial systolic blood pressure. You can obviously see that there were some pretty significant leaps and declines. So that is the main point of our case here. So thank you. Any questions?
Do we have questions from the audience? There's a microphone up here. People asking questions, introduce yourself and where you're from, please.
Ashley Clausen, Fort Worth, Texas. I did my residency in the Navy way back when people were using deep cervical and superficial cervical blocks. Do you have any experience of comparisons of general with that?
I don't. That would be something I need to look further into, but that is an interesting point. In terms of pain management after the fact?
Not so much pain management, just neurologic monitoring. You could talk to the patient.
I see.
Just a very light or minimal sedation. Mm-hmm. We did, I guess I probably did 40 or 50 anesthetics with a peripheral vascular surgeon named Andy Whittemore. And they found that their outcomes were much greater in terms of comorbidities and complications.
Okay, fair enough. No, I don't have enough information about that to say, but thank you.
Great presentation.
Appreciate it, thank you.
Add to that comment that if you're going to do carotids under regional, you have to have a surgeon that's relatively quick because a lot of these people are older with a lot of comorbidities and they can't lie flat with a retractor up like this and drapes over for very long. If you give some sedation, you have to be very careful about that too, because if they fall asleep and they wake up, they don't know where they are and they jerk their head, that's a problem too. So regional versus general, it depends on everybody together deciding what's the best for the patient, including your surgeons. You have to have surgeons that can do it under regional or it's just not really an option.
I see.
So thank you so much.
Absolutely.
One real quick other question.
Yes.
How did you determine what MAP was optimal for this patient?
So it's suggested that we go at about a 20% just based on the available literature, although that is one of the main points that I wanted to look at a little bit closer. So, you know, it's a ballpark figure, but as to whether or not that is an ideal range, probably could use more investigation as well. Thank you. Thank you very much.
Our second poster presentation is a complex case entitled Laryngeal Airway Obstruction Due to Myxedema Hypothyroidism. A case report and review of the literature will be presented by Dr. Cameron Tobler, a resident from Ohio Health Doctors Hospital.
Hello, everyone. I'm a current CA2 in Columbus, Ohio at Doctors Hospital. This is a case that I saw during my intern year with the ENT department. Essentially, I know there's a lot of busy text on here, but the main part of this case, the important part, is the myxedema coma and prolonged hypothyroidism in this patient causing subglottic stenosis as well as supraglottic stenosis. As I'll talk about, there's a lot of literature review, and there is some literature stated cases of supraglottic stenosis for patients that have had myxedema coma. But this is one of the first instances that we saw based off a literature review of subglottic stenosis in a patient with chronic hypothyroidism with exclusively medication noncompliance. Initially, we know what myxedema coma is. We all learned about it in medical school. You can get associated bradycardia, hypotension, and it can cause a fatality or morbidity or mortality for patients that evolve to myxedema coma from their hypothyroidism. This patient was a 39-year-old female. She initially had a large goiter that was radioablated. And then obviously subsequently became hypothyroid and was reliant upon synthroid replacement orally for quite some time. She also had a history of diabetes and morbid obesity to factor in to the subsequent events that happened throughout this case. Initially, she presented to the ED with shortness of breath, chest pain, fatigue overall, and she had a lot of the signs and symptoms that showed that she could be developing or producing a myxedema coma state in the ED. Initially, the ED thought it was more of a reactive airway disease problem. They gave her 6 milligrams of Decadron and sent her home, unfortunately. She then returned to the ED with more dyspnea, shortness of breath, hypoxia. Ultimately, she was emergently intubated with the ENT team and the anesthesia team called emergently to the ED. And she was ultimately intubated and taken to the ICU to figure out what was happening. Prior to her intubation, she did mention that we had an understanding that she was hypothyroid, but we didn't have an understanding of how much she was not taking her medication. And I think this is an important point to point out, is that she had been chronically non-compliant with her meds for years and years and years. And this led to more of a chronic swelling that I think led to this subglottic stenosis as well. From there, she was intubated and stayed intubated in the ICU for about 10 days total before they turned to an elective tracheostomy. Of note, her laboratory values were excessively high. Her TSH was greater than 100, I think I have on here. I know that you need binoculars to read my presentation, so I'm sorry about that. But TSH was greater than 100, and her morbid obesity did not help because there was a significant factor in potential OSA or obesity hypoventilation syndrome as well. So from there, she was intubated for 10 days, switched to an elective tracheostomy because she did not have a cuff leak, even with Valsalva movas or coughing technique. There was no cuff leak whatsoever. So our concern ultimately was we just need to switch to tracheostomy after prolonged intubation. The pictures I have here on the left side is going to be the supraglottic view. They did that is obviously her vocal cords. As you can see, the posterior arytenoids are not even appreciable. They're all just completely swollen. Most of the anatomy is completely distorted. And also she had a enormously swollen epiglottis as well. And then the picture on the right side is actually her subglottic view. If you can see, it's highly vascularized as well as it's just very, very swollen. And so this was actually when she had the tracheostomy in, and endocrinology was consulted to help treat her severe hypothyroidism. She was on like 100 milligrams of IV Synthroid for quite some time to just get her TSH levels down and get her T3, T4 normalized. From there, she was ultimately, tracheostomy was placed appropriately, and she was sent home on oral meds where she began to do very well. She continued to stick with her regimen, and she came back to the hospital to see if she could get her trach downsized and or removed, possibly. From there, she was not able to, and it accidentally popped out and it healed on its own, and she ended up doing fine. So that was an interesting resolve. Sorry, I went a little over time.
Any questions from the audience? How did you do this this fiber optic intubation? Did you give any nerve blocks? Did you give any sedation?
For the fiber optic intubation, there was no nerve blocks, and I think it was done mostly awake in terms of the fiber optic. It was more of an emergent scenario for the intubation, and my understanding is that they were able to get a view with the glide scope, but it was just swollen tissue everywhere. So they had to, I think they went down to at least a size 6 or a 5.5 tube just to get it in. Ultimately, the presentation was more about the management of the hypothyroidism, I would say, and just something to look out for.
So my question is, did you scare her enough to cause her to take her meds from now on? Or how will you do that?
Yeah, I think overall it was a very long health education talk with her. I actually was able to be in the clinic with the ENT program as well to talk with her about how important it is to follow up with her meds. And I think her understanding of having this tracheostomy really scared her into taking her meds regularly. So,
Thank you so
yeah,
much.
thank you.
Our third poster presentation is a complex case entitled Anesthetic Management of Diaphragmatic Pacemaker Placement After Surgery of a Cervical Spine Injury. Will be presented by Tamara Stojilkovic, a student from Kendall Hospital.
Hi, everyone. I am a current intern at Kendall Hospital in Miami, Florida. So my case was a case that I saw last year when I was a med student rotating at that hospital. And it was the first time we ever had a diaphragmatic pacemaker placed in a patient at our hospital. And this patient is a 35-year-old male who had a spinal cord injury while in jail. He was in a fight and subsequently had complete spinal cord syndrome of C4 with bilateral fractures, associated quadriplegia. He had multiple procedures done during his court stay, about a month. He had anterior corpectomy, posterior C3 through C7 fusion, decompressive lampectomy, bronchoscopy, and tracheostomy. This patient was a great candidate for a diaphragmatic pacemaker placement because he not only had functioning phrenic nerves, but his diaphragmatic muscle was intact. And so to get this patient not to be ventilator dependent, this is one of the procedures that the patient wanted to have done. The complexity of this surgery is mostly due to you can't use neuromuscular blockade because you need to see how the diaphragm moves. With the pacemaker placement, there are 4 electrodes in total, 2 go on each side. And throughout the surgery, the patient has to be taken off ventilation and put on spontaneous breathing to see the diaphragmatic movement and to see if it's sufficient volumes during the placement of the pacemaker. And so for this patient, we use propofol and fentanyl for induction. Maintenance was 1.2% sevoflurane. And this procedure, the patient had multiple episodes of hypotension where we gave phenylephrine and ephedrine. And we also gave calcium chloride to help with the inotropy. We didn't have to reverse him at the end of the procedure due to no muscular blockade was used. But this case was complexed by the fact that we didn't use any MSK, neuromuscular blockade. We just had to keep giving fentanyl to help the patient stay sedated. After the surgery, the patient actually did really well and is off ventilator and is now just using diaphragmatic pacemaker. Here you can see in the image what a diaphragmatic pacemaker placement looks like. It's partly outside of the body.
Questions from the audience? I have a couple. Did this patient get extubated at the end of the surgery?
Yes, they did.
Okay, because that would be a concern of mine as far as, I mean, did the pacemaker was working right away?
Yes, but
So-
we still kept the trach in place just in case if it did fail.
Okay,
So
so the
they-
patient wasn't on a ventilator, just had a protected airway?
Yes, yep.
Okay, great. And how's the patient doing now? Do you have any follow-up?
Yeah, the patient is discharged. He's back in the prison, but he doesn't need ventilator support anymore.
Do you know anything about the life expectancy of this pacemaker? Like how long is the battery? Like did they have to be changed, that kind of thing?
No, I don't, but I do know an interesting point about the diaphragmatic pacemaker placement. It actually does not increase lifespan or anything, but it is cost effective because they don't have as much complications in the hospital.
And do you know if anything has to be done to it if the patient had to come back for subsequent surgeries and electrocautery was being used?
I do not. I'm sorry.
Any other questions from moderators?
No, that was my main question is what do you do when they come back? And if you turn it off, you know, is it fine for the surgery? Does it matter? But
All right, thank you so much.
Thank you.
Our last poster presentation for this session is a complex case entitled Pseudocholinesterase Deficiency in an Ambulatory Surgery, a Case Report. This will be presented by Dr. Caitlin Elizabeth Johnson from Ohio Health Doctors Hospital.
Hello, everyone. My name is Elizabeth Gray. Actually, I just changed my name legally after getting married, so sorry for the confusion on that. But I'm going to be talking about a patient that I had when I was an intern. It was actually my first week of anesthesia as an intern, my third day, to be exact. So my patient was a gentleman that came in for an ambulatory surgery, receiving a hernia repair, no past issues with surgery. It had that same ventral hernia repaired in the past. No issues before with surgery, no family documented history of any issues with surgery before. He just had a medical history. He was hypertension. He was on amlodipine, and then he was pre-diabetic as well. He was induced with lidocaine, propofol, and fentanyl, and he was paralyzed with succinylcholine and then given a defasciculating dose of rocuronium at the time. When the robot was draped on for him, he was then paralyzed with rocuronium and then maintained on sevoflurane throughout the case. When I was intern on this case particularly, coming to check train of 4 residual blockade, I noticed within about an hour through the case, he still didn't have any twitches back, which was kind of interesting. So I ended up moving the train of 4 monitor that was originally on his right side to his left. Still didn't have anything. I ended up going underneath the drapes and placing them lowered down on his feet to see if there would be any type of train of 4 response to that as well. There was not. At Doctors Hospital, we have a qualitative way of measuring train of 4, so it's a lot more like you have to visualize if there's any twitches. At that time, the procedure was actually wrapped up. It was just the attending surgeon that was doing the case at that time. And I still didn't have any twitches back. So at that time, I did call my senior in and say, hey, I'm not seeing anything. Am I doing something wrong in this circumstance? We did change out the train of 4 monitoring. At that time, sedation had kind of been weaned down. We still not were getting any twitches at that time. We did give the appropriate reversal of Sagamedex, waited a few minutes, we're still not getting anything. At that point, our patient had about a 0.5 mac of gas on. At that time, we decided to call in the attending physician, let her know, hey, there's a concern. He should be reversed. He's not having a 24 response. We've changed monitors out. We've tried him on pressure support. He's not able to tolerate anything. He's not initiating any breaths on his own. So at that point, we made a decision to take him off of sevoflurane, transition him on a Precedex strip. We did order labs at that time. We called the ICU because there was a concern, is this some type of pseudocholinesterase that we're not seeing? So he was transitioned to a Precedex strip out of the ICU, remained intubated into PACU. Within about 30 minutes into PACU, we kind of were able to wean down his Precedex trip a little bit, and he was actually able to follow simple commands at that time. So he was able to squeeze fingers, kind of nod his head, indicating that he had recovered from his sedation, but not from his paralysis. We were able to, about an hour or two later, continue him in PACU. He was able to kind of be transitioned to pressure support, but he still needed a lot of support in order to kind of maintain his respirations. At that time, we did update the wife and decide, hey, this could be a acetylcholinesterase issue. He was transferred to the ICU. At that time, we did get labs back. There was no electrolyte abnormalities. His blood sugar was normal. We went back through the chart. He was normothermic the whole time. There was no other overlining concerns that this could be something else that's causing his delayed emergence. Later on, about 4 to 6 hours later after the procedure in ICU, he was able to be extubated successfully. Our institution does not have dibucane number testing, so we did send out a acetylcholinesterase level that had to be sent out to Mayo Clinic and came back several days later. I was able the next day to follow up with him in the ICU when he was successfully extubated and, you know, talking to him like, hey, this is a concern of what we think you might have had. We have sent off the level. You know, in the future, when you have any issues, make sure to tell your anesthesia provider, and we will update you with the level that comes back. A few days later, did come back. The level was severely decreased. It was 2,500. The normal range anywhere from 5,000 to about 7,000, so indicating that he does have acetylcholinesterase deficiency. I did talk to him a few weeks afterwards. He had not gotten any type of dibucane number testing or anything like that. I did follow up with him about a month ago and called him. He still had not gotten an official dibucane number testing. However, he did tell his family members, and come to find out he had a first cousin about 2 or 3 years ago who he's not very close to that actually had a delayed emergence from anesthesia as well and had to be intubated and kept in the ICU after his elective procedure as well, so indicating there is some kind of family issue they know of. I think this was a really good case, and I've told my co-residents about it, and I've told my interns now, and even though it was terrifying to have this case as an intern, your third day of anesthesia, it was a really great learning opportunity, something I always tell my interns too, that to kind of trust your gut. If something's wrong or feels wrong, it's okay to ask your senior, it's okay to ask your attending. And now it's definitely changed my practice, even as a CA1. Whenever I use succinylcholine, I still will monitor Train-O-4. I'm pretty on top of it before I give, if I have to give rocuronium or give some VEC or another paralytic on top of that, because I did have this case. And then for those of you that are not from the Midwest or not from Ohio specifically, there actually is a very big population of patients that have this deficiency, specifically in the Midwest and specifically in the state of Ohio. So something to always keep in mind if you're ever practicing in that area. So, thank you. Any questions? I actually did not know, and that is something that I do now. With it being a robotic case at the time, there's so much going on that when we were setting up with my attending, she's like, hey, make sure, like, go ahead and give rock. It's been 10, 12 minutes. The succinylcholine has worn off. But I did not check before I gave it, and that's something that now I do every single time because I had a case with this.
So I just had a, I guess it's a question, a statement. In my mind, it's atypical pseudocholinesterase or deficiency. And the atypical pseudocholinesterase is the genetic thing, and that's the one with the low dibucane number. But there's other things that can cause a decreased level, including pregnancy, liver disease, things like that. But it sounds like what you have is a group of people in your area that have an atypical.
Yes, yeah, and that was something I did not know until I started doing more research, and again, as an intern, not knowing that much about this, and hearing even from some of my attendings that were like, oh yeah, I've seen this before in Ohio, I've seen this several times. Because it was interesting, I had like talked to other people, like, oh, I've never seen that, and come to find out, again, it's very popular in Ohio.
That is very, very interesting. Any other questions from the moderators?
Thank you.
So much. All right, we have a couple minutes before the last session is going to start, and that's going to be the oral abstract presentations. We're going to have, that is going to start at 12:30. and it may not go till 2:30. Those presentations are going to be a little bit longer, and hopefully there'll be some questions from the audience. And then we're going to talk about awards and things later today. But thank you so much for all the authors and presenters of these poster presentations. Let's give them another hand.